Good evening, everyone, and welcome to Western Pacific and Oceania region session, Block 3B2, the Community and Public Health Practices at the Virtual Global Nursing and Midwifery Conference on the Planetary Health. In this session, we will focus on how community and public health nursing and midwifery can contribute to planetary health action in the Western Pacific and Oceania region. This region faces multiple and interconnected challenges, including climate-related hazards, environmental change, population aging, urbanization, and geographic vulnerability, particularly in the island and the coastal setting. So today, we have three presenters that each bring in an important perspective on community and public health practice. Through their presentations, I hope we can discuss how nurses and midwives can support prevention, preparedness, response, and recover, while also addressing the vulnerable population and the health equity. So thank you again to our presenters and the participants. So let us begin with the first presentation. Anyway, my name is Kumiko Igarashi. I will be the moderator for this session. Thank you so much. And then first presenter is me. So I will start my presentation. Okay. So once again, thank you so much. This is a good opportunity for me to participate in this very, very important event. My name is Kumiko Igarashi, the Research Managing Director, National Institution of Public Health, Japan. And I will talk about the climate change and public health nursing in Japan, the lessons from resilient and equitable health system. Okay, so I have the 4 topics in my the presentation. Okay, the first, the slide, this figure summarizes the key climate risks and adaptation options in selected Asian cities, including the flood, sea level rise, urban heat, extreme rain, drought, and cyclone. Since the climate impact in the Asian Pacific have already been explained earlier session, so I will not go into detail here. So let me go to the next slide. Okay. So this slide shows that the global warming is already affected the perception, the event in Japan. Observational data indicate that heavy rainfall has increased over the past century. In particular, the annual number of days with daily perception of 100 millimeters or more has increased since 1901. The short duration in instance rainfall events, such as 50 millimeters or more per hour, have also become more frequent since the late 1970s. These trends suggest that heavy rainfall related disasters, including the flood and landslide, are becoming more frequent and intense under a warming climate. So these are some of the photographs or those the affected areas in Japan. Okay. Okay, the next slide is showing their this WHO figure shows that climate change affects health through multiple pathways. It increases the climate-related hazards such as extreme weather, even heat, sea level, rise, air pollution, water scarcity, and reduced food production. These hazards interact with vulnerability factors, including the demographic, geographic, socioeconomic, and health system factors. As a result, climate change can lead to injuries, heat-related illness, respiratory illness, infectious diseases, malnutrition, non-communicable diseases, and mental health impact as well. The key point is that climate change is not only an environmental issue, but a major public health challenges requiring prevention, preparedness, and resilient health systems as well. Okay, and this slide shows the 10 key components for building climate resilience adopted from the WHO operational framework for building climate resilient health system. The framework organized these components into three main areas: risk management, information, and foundation. So risk management includes environmental risk management, climate smart health programming, and emergency preparedness and management. So information includes assessment, integrated risk monitoring, research, and communication. Foundation include cross-sectoral governments and collaboration public health services and the system, and capacity building, development as well. So for this presentation, the key point is that community health or public health nursing contribute to climate resilient health system through assessment, communication, emergency preparedness, cross-sectoral collaboration, and public health services as well. Okay, next, I will talk about the public health nurses in Japan. In Japan, public health nurses are employed by local government as public health professionals, supporting the health, safety, and well-being of community resilience. To become a public health nurse in Japan, a person must first qualify as a registered nurse, then complete at least one additional year of specified education in public health nursing and pass the national examination for public health nurses, which is spared from the nursing license. In other words, public health nurses have a nursing condition as well as specialized training and national certification to address population and community health needs. So this slide shows the number of public health nurses working at the different levels of local government. So first, approximately 6,000 public health nurses working in 47 prefectures. The second level, approximately 12,000 public health nurses work in 82 municipalities with health centers. And third, approximately 21,000 population health nurses work in around 1,700 cities, towns, and villages, which are the local government closest to residents. In this way, public health nurses in Japan work across multiple the layers of local government. So they understand the community health needs in normal times and play an important role during disaster by supporting residents and coordinating with relevant organizations. So next one is showing the strengths in the public health nurses in Japan. They have the 4 points: the community-based, population-oriented, and prevention-focused, connected on local government. And the second one, the next one is the public health nursing role across disaster phases. In the preparedness phases, the public health, they identify the community risk and the vulnerable population. and in the response phase, and as well as in the recovery phases. So overall, public health links preparedness, response, and recovery in Japan. Public health nurses translate their functions into community-level action, the reduction, vulnerable, and protect health and building resilient community as well. Okay, and even the leadership and the management also is very, very important to conduct in the community. And I try to go to the summary. The transferable lesson from Japan, that we have the 2 points. The key lesson is importance of having community-based public health professional embodied in local system before the disaster occurs. And another point, institutionalized the team-based practice and the coordination and the leadership. So those are the summary. Okay, sorry, I try to finish the session here. Thank you so much. Okay, so now next presenter, I will invite the presenter, Dr. Heimi-san. Okay. Okay. The research assistant, PhD candidate, more in Chem Nursing Research Institute, College of Nursing, Yonsei University. So, Dr. Heimi-san, floor is yours.
Okay, thank you, Dr. Kumiko Igarashi. Can you hear me well?
Yes.
Thank you. Hello, my name is Hemi-san. I'm a PhD candidate and research assistant at Yonsei University College of Nursing in South Korea. Today, I'm pleased to present our scoping review titled The Influence of Weather Conditions on Sedentary Behavior in Emerging Adult. It is a rare honor to take part in this timely and pioneering event, especially as it is being held just one day before Earth Day. In this presentation, I will briefly introduce why sedentary behavior is important from a nursing perspective, why weather conditions should be considered in relation to sedentary behavior. First, I'd like to begin with the nursing significance of sedentary behavior. Sedentary behavior, or SB, refers to any waking behavior characterized by an energy expenditure of under 1.5 metabolic equivalent, while in a sitting, reclining, or lying posture. Importantly, sedentary behavior is conceptually different from physical inactivity. In other words, even if a person exercises, they may still spend a long time being sedentary during the rest of the day. Over the past decade, daily sedentary time has increased globally, and this trend is also evident in South Korea. In Korea, adults spend an average of 9.3 hours per day sedentary, and the highest level is reported among people in their 20s. Prolonged sedentary behavior is associated with various adverse health outcomes, including musculoskeletal, cardiovascular, and chronic health problems. Therefore, from a nursing perspective, sedentary behavior should be addressed as an independent target behavior rather than being considered only as the opposite of physical activity. Emerging adulthood, typically defined as ages 18 to 25, is a critical development period marked by major social and environmental transitions, such as entering college or beginning employment. During this period, long-term health habits are formed. Previous evidence shows that university students spend a substantial amount of time sedentary with an average of 11.1 hours per day across countries, and South Korea showing the highest average among the countries included in that review. Sedentary behavior is in this age group is shaped by multiple factors. These include intrapersonal factors such as time management and habit, interpersonal factors such as social norms and social media interaction, and environmental factors such as access to digital devices and weather conditions. Among these, weather conditions is particularly important because it is a daily environmental condition that may influence how much people sit, move, or remain indoors. This leads to the question of why we should review weather condition and sedentary behavior now. Since the late 2000s, global interest in climate and health research has grown rapidly. Following the IPCC Fifth Assessment Report and the Paris Agreement, weather conditions came to be recognized more clearly as important environmental determinant of health. Previous studies have already suggested that weather may also be relevant to sedentary behavior. In addition, prior review studies have examined weather in relation to sedentary behavior and physical activity. However, these reviews did not focus specifically on emerging adults. This is an important gap because emerging adults may respond differently to environmental conditions due to their digital lifestyle and transitional life stage. Therefore, a scoping review was needed to map the existing evidence in this population. Based on this background, the aim of this scoping review was to map the characteristics and the key findings of studies examining weather conditions in relation to sedentary behavior among emerging adults. More specifically, we asked three questions. First, what are the characteristics of studies on weather conditions and sedentary behavior in emerging adults? Second, how have weather conditions and sedentary behavior been defined and measured in these studies? And third, what effect of weather conditions on sedentary behavior have been reported? To answer this question, we conducted a scoping review guided by the JBI framework and PRISMA guidance. We used the PCC framework to structure the search. The population was emerging adult, aged 18 to 25 years. The concept was sedentary behavior, and the context was weather conditions. We searched 5 databases: PubMed, CINAHL, Embase, Web of Science, and the Cochrane Library. The search covered the period from database inception to October 12, 2025. In the search strategy, we included a broad range of weather-related terms such as temperature, humidity, wind speed, precipitation, solar radiation, ultraviolet index, and air pollution indicators to capture the widest possible range of relevant studies. For eligibility, we included peer-reviewed English language human studies involving healthy population that included emerging adults and that examined weather in relation to sedentary behavior. We excluded animal and cell studies, basic science studies, studies focused on pregnant women or children, review articles, clinical trials, grade literature, and studies involving specific clinical or special population. After screening 496 records, we reviewed 421 titles and abstracts and assessed 37 full-text articles for eligibility. Finally, 9 studies were included in this review. Now, I will move to the result. First table summarizes the characteristics of the 9 included studies. All studies were published in or after 2017. Suggesting that research on this topic is relatively recent. Most studies were conducted in China, followed by the United States and Hong Kong, showing that the evidence is geographically concentrated. In terms of study design, longitudinal studies were the most common, with a smaller number of cross-sectional and quasi-experimental studies. Sample size varied substantially from very small studies with only a few dozen participants to very large cohort studies with tens of thousands of participants. Monitoring areas also varied, including university-based sample in Beijing, community-based community-based samples in the United States, and broader range regional samples across China and Hong Kong. The monitoring period were generally short, most commonly 1 day or 7 days. In addition, the temporal alignment between weather condition and sedentary behavior differed across studies, including hourly, daily, 7-day average, and long-term exposure linkage approaches. Overall, these findings suggest that the existing evidence is not only geographically limited, but also methodologically heterogeneous. Second table presents the operationalization of sedentary behavior and weather condition in the included studies. Only 3 studies treated sedentary behavior as a standalone outcome, while the remainder assessed sedentary behavior alongside physical activity. Across studies, sedentary behavior was predominantly operationalized as a time-based outcome, such as average daily sitting time, total daily or hourly sedentary behavior, or weekday sitting time, although one study used a dichotomized threshold of leisure screen time exceeding 90 minutes per day. Measurement approaches included both self-reported instrument and device-based method, reflecting methodological diversity in the evidence base. Weather condition was likewise operationalized heterogeneously, ranging from same-day or hourly meteorological indicators to 7-day average exposures and longer-term environmental measures. Frequently included weather variables were temperature, precipitation, day length, and air quality indicators, particularly AQI and PM2.5. Many studies also incorporated additional outcomes or covariate, such as physical activity, sleep, socio-demographic characteristics, health status, and neighborhood or environmental attribute. Taken together, these findings indicate that both sedentary behavior and weather condition were defined and measured inconsistently across studies, limiting direct comparability. Third table presents the association between specific weather factors and sedentary behavior in the included studies. Temperature was the most frequently investigated factor, followed by PM2.5 and precipitation. Temperature showed a mixed pattern, but cooler or milder conditions were generally associated with reduced sedentary behavior. By contrast, precipitation and poor air quality tend to be associated with increased sedentary behavior. PM2.5 was one of the most commonly examined exposures and was mostly related to higher sedentary behavior, although no findings were also reported. Evidence for other factors, including wind speed, photo period, cloud coverage, humidity, PM10, ozone, and NO2, was sparse and inconclusive. Taken together, these findings indicate that weather-related influence on sedentary behavior are most consistently observed for temperature, precipitation, and air quality, while evidence for other environmental factors remains limited. Overall, this review shows that evidence on weather condition and sedentary behavior in emerging adults is still limited and geographically concentrated. Among the weather-rated factors, temperature, precipitation, and air quality were the most frequently examined and showed the most notable association with sedentary behavior. However, several limitations were also identified. Most studies examined sedentary behavior together with physical activity rather than as an independent outcome. In addition, the included studies were heterogeneous in design, measurement, and temporal alignment between weather condition and sedentary behavior. Taken together, these findings suggest that the current evidence base is informative, but still fragmented. They also suggest that sedentary behavior should be understood not only as an individual behavior, but also as one shaped by broader social and environmental conditions. Looking ahead, both weather condition and climate change should be considered in future research on sedentary behavior. Weather condition reflect the daily conditions people actually experience, whereas climate change represent a broader long-term context. For nursing research that I thought, examining daily weather condition may be especially meaningful for understanding habitual behavior, such as sedentary behavior. Future studies should also examine sedentary behavior not only by total time, but by type across diverse global settings. Importantly, sedentary behavior is not shaped only by individual habit. It may become more severe under vulnerable living conditions such as precarious work environment or low-income housing, where opportunities for physical activity are structurally constrained. Therefore, nursing research should move beyond the individual lifestyle factors and examine the social and structural determinant of sedentary behavior. As sedentary behavior becomes a shared global health challenge, such research may help reduce health inequities and support sustainable health promotion, thereby contributing to both health equity and planetary health. Ultimately, understanding sedentary behavior in the context of weather, climate, and social conditions may advance both health equity and planetary health. Thank you for your attention.
So thank you so much, Heimi. It was very wonderful presentation. It was very interesting. And then I'd like to congratulate to conclude this research. So your presentation summarized the scoping review on how weather conditions influence sedentary behavior among emerging adults aged 18 to 25. It highlights that sedentary behavior is an independent health risk and that factors such as precipitation and poor air quality may increase the sedentary time. Their key message is more important that sedentary behavior is shaped not only by individual lifestyle, but also by weather, climate, and broader environmental conditions. It was very interesting. Thank you so much for your presentation. Okay, yeah. So we are going to the third presenter. I'd like to invite Dr. Yu Sumiya, the staff nurse, St. Lucas International Hospital, and also ICN student and early career nursing advisory group. So your floor is yours.
Thank you very much, Dr. Kumiko Igarashi. Hello, everyone. My name is Yuyu Sumiya. I am a pediatric nurse at St. Luke's International Hospital in Tokyo, Japan, and I serve as the Japanese Nursing Association representative to the ICN Student and Early Career Nurses Alliance. Today, I would like to talk about heat waves and health, specifically what is happening in Japan, what we as nurses are doing about it, and what I believe we must continue to do as a region and as a profession. I am grateful to be here alongside other speakers from the Western Pacific and Oceania, and I look forward to our discussion. So my presentation today is organized into 5 sections. I will start with a personal observation, why I, as a nurse, feel that climate change is already present in our daily work. Then I will start data on Japan's heat wave crisis, followed by the strategies and the specific role that nurses are playing. I will then connect Japan's experience to the broader Western Pacific and Oceania region, and I will close my own perspective as an early career nurse. I hope to leave you today with a clear picture of both the challenge and what we can do about it. So I want to start not with data, but with something personal. Every summer, I notice more children and patients coming into our ward with heat-related illness. The admissions start earlier in the season. The severity feels greater, and I find myself thinking, this is not just a bad summer, this is a pattern. Japan has recorded near record high temperatures almost every year since 2018. Heat-related emergency admissions are rising not just in numbers, but in severity. And as a pediatric nurse, I'm especially aware that children are more among the most vulnerable. Their bodies regulate temperature less efficiently than adults, and they deteriorate faster. This is a reality that shapes everything I want to share with you today. So let me share the numbers. In the summer of 2024, from May to September, 97,578 people in Japan were transported by emergency services due to heat illness. This is the highest number ever recorded since national tracking began in 2008. It was 6.7% increase from the already very high numbers in 2023. 100 people died. Over 2,000 had severe cases requiring 3 or more weeks of hospitalization. But the number that I found most striking is this one. 38% of all heat illnesses cases occurred at home, not on a sports field, not on a construction site, inside people's own homes. That tells us something very important. This is not just a public space problem. It is a community and household health problem. And this is exactly where nurses have a role to play. So looking at who is most affected, the elderly account for 57% of all emergency transports. Their ability to sense heat and regulate body temperature declines with age. Many also resist using air conditioning either because of cost or habit. But I want to highlight the right side of this slide because it speaks directly to my experience as a pediatric nurse. Children under 17 make up nearly 10% of transports. Their developing physiology puts them at risk, and importantly, they rely entirely on adults to protect them. They cannot call for help, they cannot make decisions about going indoors or staying hydrated. That responsibility falls on parents, schools, and health workers, including us. The 38% home occurrence figure matters here too, because for young children especially, home is where they spend most of their time in the heat. Japan has been building a policy response. The Climate Change Adaptation Act was enacted in 2018, and by now, 46 out of 47 prefectures have their own local adaptation plans. In 2025, heat illness prevention became legally required in workplaces with penalties for non-compliance. At the community level, the Cool Oasis program is one of the most practical examples. Prefectures across Japan, including Saitama, which neighbors Tokyo, designate convenience stores, pharmacies, and post offices as public cool shelters during heat events. Heat index forecast using a metric called WBGT, which accounts for humidity and radiant heat, not just temperature, are now publicly available. And at the nursing level, while we do not yet have a systematic national framework, around 50% of nurses report that they feel capable of educating patients and families about the health risk of climate change. That is a significant untapped resource. What we need now is the structure and education to support them in doing so consistently. So now I want to talk about what nurses can actually do, and I want to start not with the ward, but what happens before a patient ever gets there. This session is about community and public health practices, and I think the most important message I can share is this. The most powerful role nurses play in addressing heat-related illness is not in the ICU or emergency room. It is in the clinic, in the home visits, in the school health consultation before the crisis happens. On the left side of this slide, you can see what that looks like in practice. During outpatient visits or community health consultations, we can assess heat risk before it becomes an emergency. We can educate families about home temperature management and hydration, not in July when it's already dangerous, but in May and June before the peak arrives. We can advise on safe outdoor activity on high heat index days. We can connect vulnerable patients, elderly people living alone, young children to local resources like Cool Oasis shelters. And we can teach families and early warning signs of heat illness so they can know when to seek care before deterioration sets in. These conversations happening in community settings before August arrives are what prevent admissions from happening in the first place. Of course, prevention is not always enough. On the right side, you can see what happens when a child does reach the ward. We manage IV fluids, cooling protocols, continuous vital sign monitoring. Children are particularly challenging because they can appear relatively well and then deteriorate quickly. And also one of the most important things we do at this stage is discharge education, making sure that when this child go home, the family knows how to prevent it from happening again. But there is a gap between what nurses can do and what is currently supported. Only about 42% of nurses have accurate and comprehensive knowledge of how climate change affects health. We have the access, we have the trust of patients and families. What we need now is the knowledge and the structure to use that position consistently. Japan's experience with heat illness is not unique to Japan. The Western Pacific and Oceania region faces climate health threats across very different geographies, but with a common thread. Japan deals with tropical typhoons and extreme urban heat. Pacific Island nation face sea level rise, flooding, and waterborne diseases. For some communities, climate change is not just a health issue, it is an existential one. In Australia and New Zealand, extreme heat, intensifying bushfires, and flooding are driving rising respiratory and cardiovascular impacts, mental health burdens, and compounding climate disasters. What we share across this region is this. Nurses are the healthcare workers closest to the community. We are in homes, schools, clinics, and wards. We are often the first to notice when a patient is struggling and the first to ask why. That positioning makes us uniquely able to detect climate-driven health challenges and to educate and respond at the community level. Japan's experience building heat response systems like the WGBT forecast, the Cool Oasis shelters may offer practical lessons that are adaptable to other contexts in this region. I want to close that content section with 3 things I personally believe as an early career nurse. First, climate change is not a future problem. It is already in our wards right now. The patients I have cared for this past summer are evidence of that. We do not need to wait for more data or more policy before we act. Second, we are the generation that will work through this challenge the longest. Early career nurses will be practicing for the next 30, 40 years. The patients being admitted for heat illness today are the same patients who will need care as this crisis worsens. That gives us both the deepest stake in addressing it and a responsibility to make our voices heard. Third, small daily actions add up. Adding an environmental risk question to patient assessment, framing air conditioning use as medical advice, not a lifestyle preference, teaching parents about safe outdoor activity on extreme heat days before sending their child home. These are not grand gestures, they are nursing actions within our scope that we can begin doing today. Climate change is not a future threat. It is already in our wards, our communities, and our patients' homes. As nurses, we are already on the front line. Every summer, we see it. Every discharge education session is an opportunity. Every patient assessment is a chance to ask one more question about their home environment. The question is not whether we act, it is how soon. Thank you very much for listening.
Yeah, thank you so much, Yu. I think I appreciate 2 of you to manage their they finished your presentation on time. So at least we have the 15 minutes for discussion, question and answers. And then as maybe we are waiting for the questions from the audience. Maybe I'd like to ask two of you if you want to add on some more points, whether you wanted to add, or may I ask some questions to two of you? Is it okay? Heimi-san, is it okay?
Yeah,
Oh,
that's
okay,
okay.
yeah. Maybe as you are answering, maybe you can put on your own the additional information as well if you need. And then it was very interesting the research outcomes. However, I just want to find out how can nurses translate the findings on weather-related sedentary behavior into practical community health interventions.
Yeah,
Yes.
thank you. Thank you for your question. Okay. I think nurses can translate these findings into practice by treating weather condition as a meaningful context for everyday health behavior rather than simply background information, right? Yeah, actually, ordinary research has the background information. Weather condition is just background information so far, but I think it's more meaningful in our future research. So, for example, on days with extreme heat, heavy rain, or poor air quality, nurses can identify these conditions as potential risk period for prolonged sedentary behavior, and we can provide some timely guidance for the patient or general populations. And in community settings, this could include short digital prompt and indoor movement suggestions for student workers and other groups who may be more likely to stay sedentary behavior. And I think from a nursing perspective, the goal is not only to tell people to exercise more, but also to help them reduce sedentary behavior. You know, modern people have suffering from sedentary behavior all time. Like us, we are all suffer from sedentary behavior. I think it's a modern people's and the social issues. We need to provide some guidance for them, for our patient and our participant. Yeah, and nurses can also work with schools, university, and workplace and local public health systems, to develop weather sensitive health promotion strategies such as reminder to break up the sitting time or recommendations for safe indoor alternatives. In that sense, weather information can a practical tool for community-based nursing assessment and prevention. Thank you.
Okay, thank you so much. I think the nurses are working their conditions or different places. So we have a big opportunity to influence our evidence-based the health promotion or the interventions. It's very, very important. Maybe if you have some question to the Amy or any comments?
It was actually my first time knowing about the sedentary. And I think it's a really big issue because a lot of people work in the office and then, if you're just like working, you just forget if you're like really focused, you just forget to, move around. So I think, setting like a time, okay. So like I'm using Apple Watch and then they say like, okay, maybe it's time to stretch, work out. And I think that like notification or something that small action is very important. Thank you very much for your presentation.
Okay, thank you so much. So maybe I can I will ask you also to make the comments. Maybe as you mentioned that there is not enough opportunity for the nurses to learn about the climate change and the related health risk. So what kind of education or policy support is needed to strengthen the nurses' capacity to respond to the climate-related health risks? And maybe you can include in Japan, the situation in Japan, how the nursing students
Mhm.
can their study on it.
Okay. Thank you for that question, Dr. Kamiko Igarashi. I think this is one of the most important gaps we need to address. From my own experience and from the data, as I said, that only like 42% of nurses in Japan have accurate knowledge of how climate change affects health. And then despite like 72% recognizing it as an important issue. So that gap between awareness and knowledge tell us something that nurses want to engage with this, but the infrastructure to support the system is not there yet. So what kind of support do I think is needed? I think the formal education. So like starting from this year, 2026, planetary health will be incorporated into Japan's national nursing education curriculum. And this is a really meaningful step, but it only reaches new graduates. The majority of nurses already working in hospitals and communities need to access to continuing education on climate and health integrated in service training programs, not as an optional add-on. And also practical tools at the bedside and in the community. I think it is not enough to teach the theory. Nurses need concrete guidance, how to include environmental risk factors in patient assessment, how to counsel families about heat safety, how to connect patients to community resources. These need to be built into clinical protocols. And also, I think institutional support is very important. Individual nurses cannot do this alone. So like hospital nursing associations and health systems need to signal that climate informed care is part of professional practice, not like a personal interest. And as nurses, we are already on the front line of this crisis. What we need now is for the systems around us to catch up. Thank you.
Yeah, thank you so much. And then I appreciate the update information for the educational, their kind of the advanced the situation in Japan. And then so far the curriculum has been already set, but I think we means the teaching side also. We really need to update ourselves. But I think that it's not yet ready for all the lecturers to teach how to teach those the things to the student. But at least we really need to tackle on it. Yes, thank you so much.
I have a question.
Oh yes, please.
Yeah, you
yes,
two
Amy.
are in Japan, and right?
Yeah.
Yeah,
Yes.
I'm in Korea. Yeah, so we can compare with each other country. Yeah, so how about your academic field? Your undergraduate student have the lecture when it comes to climate change in these days. How about the education field or practical field?
You can answer.
Yeah, you too. I'm sorry.
Yeah, because
It's a
I
general
think
question.
you're
Yeah.
so recent time graduate from the university.
I'm
You
sorry.
have the good
Yeah,
ideas.
because I thought
Yeah.
Japan has more advanced curriculum in the undergraduate curriculum when it comes to climate change because you are more facing with natural disasters such as earthquakes or typhoon or and so on. So how about your curriculum? And yeah.
Mhm. Um, Last time I graduated undergraduate like 5 years ago, but at my university there was like a curriculum for like what we as nurses can do when disasters happen. So
Uh-huh.
what I learned about was when like earthquake happens or when tsunami comes, like what nurses are doing in that moment. And but we didn't really learn about like heat illnesses. So I like while I was preparing for this presentation, I learned a lot from it. So maybe I think in the future, I think when we include more about heat illnesses or even like the natural disasters, I think students can learn a lot from it.
Okay, yeah. Actually, your presentation is so amazing for me
Oh, thank
because, yeah, because we are just focusing on vulnerable people for climate change, such as elderly people. But your field is on the pediatric
Yeah.
world. Yeah, so it was so interesting. And also, um, 38% happen at home. Is
Yeah.
it also, it can apply to children too?
Oh yeah, I think the 38% includes elderly and also the kids.
Oh,
And it was actually surprising for me because I thought like a lot of heat illnesses occurred at like a sports field or at schools, but it was actually at home. So I think some of the parents they don't know that children are vulnerable, so they don't really um keep them hydrated or like put air conditioning on. So I think we should communicate people in the community as well. Mhm.
hmm.
Thank
Yeah,
you.
I think in Japan, their practical side is more advanced than their education level, I
Okay.
think. Yeah. If you go to the health center, maybe the other, as I mentioned, the public health nurses tackle their heat, their issues as well. So they have to they identify the places there where those vulnerable people can gather when they have the heat situation. So when the student goes to uh, the practical the sessions in the field, they can learn how their situation is going on. Then it's not only the how to do that, how they also the how relate to the climate change as well. That is the one of the maybe the advanced the things, the practical. Thank you. So I think that we still have the 4 more minutes, and so uh, is there any clarification, and
Uh,
then maybe the additional the comments on those others the presentation?
Okay, you,
Mhm.
do you have any uh, plan to research further?
mhm. Research further about
Yeah,
the health.
about, yeah, this.
Mhm. Um, Research, I think it will be a challenge for me, but because I've been working as a nurse, so what I want to do now is I want to, you know, make like a pamphlet for discharge when in the pediatric ward because I think we should set like how to educate the parents, and we want to make like a storybook for
Mm.
children so they also know the signs when they're like feeling sick. So I want to do something in the ward, and if I have a chance, yeah, I would want to do some further research about it. Yeah.
Okay, so thank you so much for the wonderful discussion, and then the organizer said that we can close now. So
Okay.
I appreciate the participation, and then I hope that we can continue to collaborate and then have the network in future. I think so.
I hope
Thank you
so.
so much, and we
Yep,
can go back to the webinar. Okay,
Thank
see you then.
Thank
Thank
you very
you.
much,
Bye bye.
everyone.
Thank
Thank
you.
you so
Thank
much.
you.